Multiple sclerosis. Multiple sclerosis, or MS, is a chronic health condition. According to Ehrman et al. 09, MS is a demyelinated disorder in the central nervous system where patches of sclerosis attach to the white matter of the brain and spinal cord. These scleroses turn into scars, which create problems with the transmission of nerve impulses. According to Lundy-Ekman 13, MS most commonly occurs between the ages of 20 and 40 and is considered to be 3 times more likely in women than in men. This presentation will outline different features that define MS. In particular, the presentation will discuss the cause of MS, the signs, the symptoms of the disease, and how the disease develops. Additionally, the presentation will focus on how MS affects the nervous system and therefore its effect on motor control. Presently, there is no cure for MS. However, each progression or development of a new system is treated to manage the condition. This is done through medical intervention and the implementation of exercise programs. Each of these focus points regarding MS will be analysed via peer-reviewed research articles. The purpose of this PowerPoint is to educate the public on what to look out for in regards to the onset and development of MS, as well as the basic physiology behind what is happening to the body throughout the progressions. According to Ehrman et al. 09, MS is an inflammatory autoimmune disease that affects the oligodendrocytes and the myelin sheath in the brain. According to Lundy-Ekman 13, when individuals have MS, the body's immune system releases antibodies which attack the oligodendrocytes. When damage occurs to the oligodendrocytes, demyelination occurs in patches in the white matter of the central nervous system, CNS. This demyelination is known as plaques. This formation on the CNS neurons causes the signal sent from these neurons to be either slowed down or blocked entirely. According to Kelly 96, the cell responsible for the immune system and its responses generally are not found in the central nervous system and therefore should not be able to cross the blood-brain barrier. The blood-brain barrier acts as a blockage in separating the central nervous system from the peripheral blood supply. However, in MS, this barrier is broken down. According to Burgoyne and Ward 08, the body has 2 main systems for protecting against foreign antigens. The first is called innate defense and involves barriers like skin and mucous membranes, stopping harmful antigens from entering the body. If this fails, the second line of defense is adaptive defense. This involves the body targeting foreign antigens and killing them. With MS, the body can misinterpret the difference between harmful antigens and normal body cells, resulting in the body killing the wrong cells. The cells responsible for killing these other cells are known as the T lymphocytes, or T cells, and B lymphocytes, or B cells. According to Burgoyne and Ward 08, with relation to MS, T cells are responsible for releasing inflammatory-induced cytokines, which recruit macrophages. This causes the destruction of myelin protein. B cells release antibodies that specifically target myelin and therefore attack the oligodendrocytes. The cause of MS still remains unknown. According to Pullman et al. 06, it is due to a combination of environmental factors and a genetic predisposition to MS. According to Hertzler et al. 07, MS can be triggered through a viral infection, which causes the destruction of the oligodendrocytes. Chang et al. 07 conducted a study which indicated that demyelination occurred simultaneously to a reduced ATP source availability, and therefore a decrease in physical function. However, research is still being conducted into the cause of MS development, and therefore what preventative measures can be implemented to decrease an individual's likelihood of developing MS. Lundy-Ekman 13 proposes that the signs and symptoms of MS are overall muscle weakness, difficulties with vision, both impaired and double, lack of coordination, slurred speech, and potential disruption to the individual's memory and emotions. Miller 98 suggests that early indications of the development of MS include difficulties with basic motor functions and paresthesia, which according to Furukawa et al. 07 is an ongoing feeling of tingling, often referred to as a feeling of pins and needles. According to Ehrman et al. 09, the initial symptoms occur due to a demyelination of the central nervous system. The most common initial symptoms are somatosensory problems and optic neuritis. Beck et al. 93 says optic neuritis is when the optic nerve is inflamed, thus causing difficulties with vision. Ehrman et al. 09 suggests that an advanced case of MS the muscle weakness can also manifest into involuntary movements or spasticity. According to Archibald et al. 94, an overall feeling of fatigue is considered the hardest part of the symptoms to deal with. It becomes more evident after routine work such as house cleaning or grocery shopping. Other common symptoms of MS are vertigo, sensory loss, and nystagmus, which according to Zahn 78 is involuntary movement of the eye. Matthews 98 says both men and women suffering with MS have bladder problems and sexual dysfunction. Crandall et al. 05 adds that those diagnosed with MS may also have an abnormal sweating response, resulting from difficulties with thermoregulation. Table 30.1 from Ehrman et al. 09 demonstrates an outline of what is a sign and what is a symptom. According to Bernardin et al. 91, patients with MS have a high risk of developing depression due to a decreased quality of life from symptoms like fatigue and muscle weakness. According to Ehrman et al. 09, this causes a decreased participation in work and social interactions. According to Lublin et al. 96, there are at least four different progressions or forms of MS. These include relapsing remitting, primary progressive, secondary progressive, and progressive relapsing. During the relapsing remitting stage, the patient will either develop new signs and symptoms, or old signs and symptoms will return or worsen. During the remission phase, patients will either fully recover or the symptoms will decrease in severity. This occurs in 85% of MS patients. Lundy-Ekman 13 states that the secondary progression occurs to those who don't receive treatment during the relapsing remission phase. During this phase, the patient has a continuous neurological decline and less frequent relapses or remissions. The third phase is the primary progressive. According to Ehrman et al. 09, the disease would have an onset, then plateau with potential slight improvements. However, during this phase, the disease will continuously worsen, with no obvious relapse or remission periods. Lundy-Ekman 13 suggests that this stage mainly contains spinal cord symptoms and occurs in 10% of all diagnosed cases. The final phase is progressive relapsing. The patient's physical function continues to decline. Although there were slight relapses and partial remissions, the patient in this stage will never fully recover from a relapse. This occurs in 5% of MS patients. The spasticity from MS affects the individual's motor control and movement patterns. According to Matthews 98, the spasticity will reduce the individual's capability to control their muscle movement when participating in basic tasks of daily living, like walking. Tasks of active daily living involving holding or carrying an object become more difficult due to tremors. Tremors also impact on coordination during physical activity, in particular when object manipulation is required. According to Ehrman et al. 09, balance is also compromised due to MS. This affects their exercise modality. For more developed cases where the patient requires assistance to remain balanced, exercise on a stationary cycle ergometer is optimum. For those with little ataxia, a treadmill is fine for exercise. A study by Sosnov 11 analysed movement patterns of someone with MS, in particular how MS affects their movement while standing stationary and their gait while walking. Results showed that while standing, the MS patient struggled not to sway. Additionally, the MS participants found it hard to modify their gait to correspond with the varying treadmill speeds. MS is not considered a curable disease, but rather managed by controlling the symptoms. Ehrman et al. 09 suggests the main treatment for managing spasticity and tremors is through drug intervention therapy. Petterjohn et al. 04 suggests that MS has multiple signs and symptoms throughout disease progression. Many forms of drugs are implemented. This includes immunosuppressants, corticosteroids, immunomodulators, and antispastic. Immunosuppressants do as the name suggests, by suppressing the body's autoimmune effects on myelin, and are most effective for patients who have a slow-developing strand of MS. Allen et al. 97 believes that immunomodulators modify the immune system to delay MS progression and short-term severity of the condition. Comston 98 suggests that although corticosteroids don't reduce the severity of the disease, it decreases the recovery time required after each relapse. However, long-term use of corticosteroids can cause high blood pressure and bone softening. This table from Sibley 96 shows a list of MS interventions. However, according to Coffey et al. 03, only thalamiectomy and thalamic stimulation have proved beneficial in MS management. The rest of these methods have not yet been proven successful, and therefore, according to Ehrman et al. 09, are considered investigational. Treatments such as stem cell therapy have been successful in animal-based trials, but are still being implemented into human trials. Petagen 04 refers to pain as a direct cause of the plaques located in the nervous system, is managed with tricyclic antidepressants. Fatigue is another common problem with those suffering from MS, and is particularly present when the individual partakes in physical activity. Coyle et al. 95 suggests that amantadine and pemeline are used to combat systematic fatigue. Ehrman et al. 09 proposes exercise for managing MS. A single-blind study by Erickson et al. 13 involved a 12-week group exercise program with 99 participants. Results revealed that participants all improved their balance, spasticity, quality of life, and functional level of MS. The subjects completed aerobic, strength and flexibility work, with 3 sessions per week. This research is supported by Casa et al. 13, who studied the effects of exercise on improving the individual's strength, mood, and basic bodily function. Results showed that by participating in regular exercise, MS patients were able to perform tasks of active daily living more effectively. Similarly to the healthy population, MS patients should have an exercise program that includes cardiovascular, resistance, and flexibility training. However, it's important to consider the signs and symptoms associated with MS and the implications this has on exercise. This table demonstrates the benefit and things to consider when incorporating aerobic, resistance, and flexibility training on an individual with MS. Baker 03 suggests because MS patients can have problems with thermoregulation, when participating in cardiovascular activities, the individual needs to monitor their heat levels. Cleland 72 suggests that this can be done by exercising in well-ventilated rooms and replenishing lost fluids. Additionally, as previously mentioned, exercise bikes are optimal as some MS patients develop tremors and have difficulties with balance and spasticity. A study by Efekari et al. 12 consisted of 24 females in an 8-week resistance training program. Results showed that the resistance training helped increase the participants' strength and improve their daily functioning. As MS can cause muscle loss or weakness, a resistance program proves vital for maintaining an individual's strength and ability to participate in tasks of active daily living. Ehrman et al. 09 suggests that MS patients don't use free weights unless they have a spotter with them. This is due to potential dangers caused by spasticity. Ehrman et al. 09 also suggests that range of motion exercises are important for MS patients, as joint stiffness and decreased flexibility are common in MS patients, and therefore, to avoid further injuries, flexibility exercises are vital. In summary, multiple sclerosis is an autoimmune disease that occurs as a result of damage to the oligodendrocytes. This causes demyelination patches in the white matter of the central nervous system. This demyelination blocks the signal from leaving the neurons and travelling to the necessary pathways. It is still unknown as to the exact cause of MS, but it is believed to be as a result of either a viral infection or a combination of genetic and environmental factors. There are many signs and symptoms of MS, which can affect tasks of active daily living. This includes muscle weakness, tremors, spasticity, balance, fatigue, and difficulties with vision. The 4 stages of MS are relapsing remitting, primary progressive, secondary progressive, and progressive relapsing. However, through the use of immunosuppressants, corticosteroids, immunomodulators, and antispastics, and exercise intervention, MS can be managed to continue to live an active, healthy lifestyle. This is the picture reference list, and these are my content